We know that our state ranks 49th, sometimes 50th in some important health measures and outcomes. In Louisiana, that's driven by a number of things. Certainly, we've got a high prevalence of chronic conditions, but we also have a number of social factors. Those have now been labeled social determinants of health. And we think we need to deal with both of those. We think we need to deal with prevention. It's a lot easier and more efficient to prevent disease. Primary care is really the backbone of how care should be delivered. Healthcare today is really complex. Anybody who's had to try to navigate the healthcare system, you know it's hard to get around. What a primary care physician does is get to know you as a person, gets to know your family, gets to know what's important, and then working with you, they help keep you well, and if you get ill, return you to your best status of health. The Quality Blue Primary Care Program is really designed to support primary care physicians with data and information about their patients they may not have, information about how they're performing on the management of chronic conditions, and support services to help them do a better job in their practice. We're very concerned about people being able to have affordable access to health care. There's no one single solution, but if we can work with physicians, hospitals, and others to bring down the actual cost of health care, then we can bring down the cost of health insurance, because what drives the cost of health insurance is the cost of underlying health care. So the Quality Blue programs, Quality Blue Primary Care in particular, help create a support infrastructure with physicians to drive down that cost of care while increasing quality. We believe that health care really should be oriented and centered around the patient, our member, and it should be convenient. The experience should be as good as it can be, and that we ought to be able to improve that experience, improve the quality of the care while helping to bring down costs. When I left clinical practice and got into the health insurance business, which was more years ago than I want to say, but more than a couple of decades, we were grappling with three main problems in healthcare. Costs were too high, quality was not where it should be for the money we were spending, and access and convenience were also not where we wanted them to be. We've made some incremental improvements over the last 25 to 30 years, but candidly, we still struggle with those same three issues. The Affordable Care Act was supposed to help improve access, and for a brief period of time, it did. Unfortunately, in Louisiana, we only have about 50% of the people on the individual market that were there when the Affordable Care Act first came out. And the primary reason that we've seen that loss in membership is the cost of health care, and hence the cost of health insurance is too high.
I think the value-based programs in general are important because we give providers a reason to care. So for example, if you are in a pure fee-for-service environment, a doctor is being paid for the services that they are offering, so they really don't have time for you to talk about other things for which they're not paid. For example, talking about diabetes and prevention and wellness and whether someone should be taking their medication on time. All of that adds up to create a better profile of health. We, because of value-based programs, can actually measure a lot of these, what we call quality measures, which is what today is all about, and really incentivize the physicians on overall health of the individual. And that takes us away from really treating disease to try to prevent disease. In general, if you can treat these diseases, I often say that these are the diseases of information. We know how to treat diabetes, but we need to give the right information, right knowledge, right education to our members, to their caregivers, and so on and so forth, as to how to manage that disease. So diabetes is a good example. If you manage it well, you won't have complications that occur as a result of diabetes. You'll have fewer heart attacks and strokes. You'll have fewer eye complications, fewer complications of kidney, renal disease, and so on and so forth. So if you can manage it well, not only can you slow down the progression, but you also avoid very expensive complications that could occur later. So this is a perfect example where you're improving quality of life now, but you're also reducing the cost in the long run. What we find is that doctors have data on members and we have data on members, and it's only when you combine the two and apply advanced analytics on it can you really figure out the true needs of that member. So doctors obviously have a lot of clinical data. It's in their EMRs. We are able to use this platform that you referred to, data platform, to get that data. We're able to combine it with claims data. So when one of the members gets hospitalized, for example, somewhere else, and doctor may not be aware, we're able to provide that information back. We're able to measure all of that into well-defined quality measures so that it's an apples-to-apples comparison in terms of quality across the network. All of that provides feedback. We are able to look at care gaps, so when someone walks into these doctor's offices, we are able to tell who have had their mammogram, who have had their A1C test, for example, who's taking their medications or not, and things like that. So all of that allows that doctor to practice much, much better. Because we provide information in near real time and we provide actionable information. But that's only possible because the data from both sides comes together.
It's becoming more popular because it's a better way to practice, because it incentivizes physicians on what's important, patients doing better, than it is incentivizing people just to see more and more volume. It really puts money behind what's important for our patients, and that's their outcomes, that they're having their diabetes controlled, that they're having their blood pressure controlled, that they're doing better overall. And so it's important to put incentives behind the measures that matter for patients and not just seeing lots of patients. So Louisiana is ranked 49th last year in health rankings, so there's a long way to go, and I think this is a great way to say let's put an emphasis on making sure that patients in Louisiana have quality care, that they're doing well in their diabetes, that they're doing well in their hypertension, that they're getting the care that's recommended by national boards. And so I think it's a great way to help the state and to make sure that we're truly measuring what's happening, that it's not just we're doing a good job, that there's data showing that we are doing a good job. It changes how you're reimbursed, and so hopefully you do not have to see as many patients, and hopefully you get rewarded for using innovative ways to practice, for using a team-based model, for using technology to help you to take care of your patients, for thinking outside the box and really, keeping patients outside of the hospital and keeping them out of the emergency room. And so you get rewarded for things that matter and that matter in patients' lives. It goes back to having a clear why, then understanding why you want to do this and knowing why, what you believe in. And I think that drives everything. And then I think being innovative, thinking outside the box and setting time to meet and really looking at your staff as an asset, not just looking at them as employees, but looking at them as team members.
Hypertension is the world's leading risk factor for cardiovascular disease and death. And this was recognized by the World Health Organization about 2 years ago. It also is the world's leading risk factor for disability-adjusted life years, which is a measure of how people can work and be productive in society. And hypertension is one of the things that causes that to go awry. So that's very important. For example, heart attack or myocardial infarction can be prevented. Angina, chest pain related to exercise can be prevented. Congestive heart failure can be prevented. Stroke can be prevented. And of course, you recognize these as some of the leading causes of death in the cardiovascular disease world. The guideline basically did three things. The first one was it reclassified hypertension to a lower blood pressure category, namely anything above 130/80 is now stage 1 hypertension. Secondly, it provided new thresholds for the drug treatment of hypertension, and that is any blood pressure above 130/80 in people with high cardiovascular risk. And the third thing that it did was to lower the blood pressure target Well, it used to be 140 over 90, now it's 130 over 80. So your blood pressure, once you're on medication, should be less than 130 over 80.
One of the problems with healthcare is that the incentives for providers are not always aligned with the health of members. So these alternative programs make sure that physicians and other providers get paid more if their patients are healthier, not just paid for procedures or paid if their patients are sick. Well, there are two components of it. One is if you're measuring outcomes and if you're measuring health, providers have an area of focus. If there's an area of measurement or focus, there's often an opportunity for improving. The second is you don't want there to be perverse incentives to patients being healthy. So these programs really force folks to focus on the health of members, not just their illnesses. And then there's an effort to look at areas and times in between visits with providers, really what happens in patients' lives on a day-to-day basis. Well, the healthcare landscape is relatively complicated, so often providers only know about what happens within the four walls of their area of providing care, or their hospital or their clinic. Patients get care all across the continuum. So one way that we can help as a payer is to provide information to providers about what happens with patients when they go other places in the healthcare ecosystem. So the coordination comes from being able to let a provider know that, yes, Mrs. Jones had an immunization done at Walgreens. They may have had a procedure done at a competing facility across town, plus the additional data that I have about a patient when I see them in my office. The infrastructure required to focus on health for members is really relatively broad and deep. And often a single provider in a practice or even a moderately sized practice can't have the resources, doesn't have the resources to provide all the support that's needed. So we partner with those providers in providing wraparound services like our Stronger Than services, which are really around care, case, and disease management. So if a patient maybe needs a dietitian to help them eat better, if they need support in their care and case and diseases with understanding their disease better and other social and support areas, we provide that to our members in a partnership with providers, particularly those who are unable to provide those services on their own.
It allows us to have access to data that we didn't years ago, helps us identify high-risk patients who certain medical conditions that are currently not controlled, and helps us to identify them, have outreach as a team with our clinic as well as Blue Cross to get them under better control. Provider satisfaction has been impacted. We all enjoy taking care of patients, but I think when you have a tangible outcome, in terms of control rates for certain chronic disease processes like high blood pressure, diabetes, et cetera, when you see that you're taking better care of your patient panels, I think that's very much rewarding to each individual provider. So I think from a provider standpoint, that certainly helped. Having access to data analytics that most practices can't afford unless they're in a larger network is a huge benefit. Being open-minded and always amenable to change, I think from a provider standpoint is very important. And I think if you have that kind of ingredient in place, incorporating new emerging best practices, helps drive better outcomes for patients and better provider satisfaction for the clinicians within your clinic or health network.
This is an important event. The program that you all participate is important. I would say it's increasingly important as we go through time for several reasons, and I'm going to try to give you a little bit of a macro view of why that's important. The other reason that the Quality Blue primary care program is important is because I trained as a primary care general internist, and it's good to I think understand why primary care is important. The program itself, when it started in 2013, and I was not here then, but I think the basis for the program remains true, which is if we can work together with primary care physician, other providers in the healthcare system, with the health plan, around a shared set of goals and objectives that focus on keeping people healthy, improving quality, and lowering costs. If we do that together, we will both be more effective. And as you'll see from the results this year, and we've seen it in prior years, the results are really outstanding. I mean, not just in terms of the management of some of the chronic conditions, whether it be hypertension, stroke, et cetera, or the cost of taking care of these people. I think we've demonstrated that this program, by aligning ourselves, can be effective. And I think a challenge as we move forward is how can we build on it further, how can we expand it, and how can we make it even more effective. The individual market here, and I'm sure you all are seeing this, we had a period where premiums skyrocketed 30 to 40% a year. If you don't know, for the first time since the Affordable Care Act came out, insurance premiums in the individual market actually going to go down in 19. We're not the only state where that's going to happen. But it argues, at least, absent any more curveballs from Washington, D.C., and there probably will be some, the market had stabilized. So that's kind of good news, right? Problem is that it stabilized at a price point where we have priced a large portion of people in Louisiana out of access for health care. So we've made health care unaffordable, and that's sort of the issue. The other bad news is that whatever stability we've had, I'm worried it's going to go away. So what do we have now? So we have expansion of association health plans, which are going to allow small employers to band together and bend some of the rules that the ACA had. That's just going to increase the risk in the exchange population. We've got the short-term limited duration policies that are coming out, which, by the way, are not great because they don't cover everything. Our policy that we're putting out there won't have a pre-existing exclusion to it. It will have medical underwriting, but it provides everything: maternity care, behavioral health, drug coverage, etc., but only if you're generally a favorable risk, and it will cost between 40 and 50% less than the ACA policy. So while it's not great public policy, if you're one of those 100,000 people that lost coverage and you're worried about getting into a wreck on one of the interstates and not having coverage, it's probably a reasonable bridging option for you, absent being able to afford something else, which is why we want to provide it, because we want there to be something there. But I am worried that once we're past this midterm election, it either one of two things is going to happen. Either the Republicans can control both houses again, and they're going to try to do stuff that's probably not going to be stabilizing, or the Democrats are going to control the House, the Republicans will control the Senate, and we get nothing done, and we're still going to have problems that aren't stabilized. The average cost of health insurance for employer contributions for family coverage was almost $20,000 a year. So if you're an employer and your cost of doing business, that's your cost as an employer. For every employee that buys family coverage, you're spending about $20,000 a year, which is a 55% increase from 10 years ago, but even over the last 5 years, it's a 20% increase. Those increases are completely outstripping revenue growth in companies, profitability growth, et cetera, which is why companies have been shifting more and more of the costs to the individual employees, so that while those costs went up 65%, the employee contribution went up 65%, right? So our company probably is not that dissimilar from a lot. Our employees actually now pay out of pocket about 25% of the total cost of their health care, even though they have insurance, between their premium contributions and what they do through deductibles, co-insurance, co-pays, etc. It's comforting to me to know that the work that we're doing together in Quality Blue Primary Care is making solid progress around those three issues of trying to address cost, trying to address access, and trying to address quality, while we struggle to deal with what the politicians hand us. So I would just say thanks. We want to continue to be your partner.
I'm particularly happy as I've sort of just finished my first year. I'm happy that I've gotten the thumbs up from Steve to continue my second year as a newbie in insurance. Driving down cost, it's clear to us that if folks are involved in our accountable care organization programs and in our value programs, that we make progress along decreasing the burden that members experience and that companies experience as they seek to purchase insurance and to receive care in our ecosystem. One of our concerns is really not just on the raw quality improvement, it's really on the value of care delivered. And so I've underscored a couple of constructs here. One is really around the idea that the quality of care is not just the quality metrics that we reviewed, but also this idea that the care has to be affordable. Steve did mention the issue with prescription drugs. But I'll share another anecdote, and it was really around trying to get members focused on colon cancer screening. And so if you talk about sometimes the fragility of individuals, even if you have just a small deviation that has a member getting instead of a generic, a brand prep for their colonoscopy, you could turn what would usually be a $0 copay for a member into a $300 experience to try to get the colonoscopy that they need for their care. The reason I underscore it again is that as we're pushing collectively to have things done, like have people follow their diabetic regimens, we want to partner with you to find smart ways to make sure that the barriers that members experience in trying to get the care that we've recommended collectively to the population, that they have no barrier to getting that care.
What a privilege it is to be here this morning and to be introduced by one of my former medical students and to see many friends, including. We're going to talk about what's new, and I don't have any disclosures, unfortunately. So the first major change, and there were many major changes that occurred with the new guideline, is in the classification of blood pressure, a rather fundamental issue. And this slide illustrates the changes in the classification of blood pressure since the JNC7 guideline was published in 2003. There was this very large category of pre-hypertension in the orange color here. And for the lower tier, 120, 129 over less than 80, we made that category elevated blood pressure, hopefully to convey the fact that there's still some risk in that category. My opinion is that one should give 6 months of intensive lifestyle modification to the best of your ability, and that if that fails and the patient is in the high-risk category and you haven't made any headway, then I would recommend initiating antihypertensive drug treatment.
It's been amazing just to get to know the team here in Louisiana and to see the difference that has been made in the past 5 years in practice transformation. You've got a great team and you're doing great work in a population that greatly needs it. How do we establish a culture for transformation? How do we rise above the challenges that we see day to day in primary care and build a culture that is resilient, able to tackle the challenges? That is my passion. I supervise 14 clinics in Northeast Florida and Southern Georgia, and I see day in and day out the struggles of our physicians, our providers, our teams, and it's challenging. There's a lot of issues that are causing our providers to struggle. The next thing that we have to do, the next key element we have to look at is how do we build the right team? You know, as we're looking at making a practice that can handle transformation, that can stay with the challenges, we have to think about, do we need different team members? Do we need different roles for our team members? This is important. So again, we need to get different people, different representation. It may not be the usual people. We need to make sure that our medical assistants are represented when we start having a conversation. Our care managers, our navigators are represented. A big one is IT. If we looked at burnout, again, 3 of the top 4 reasons, multiple studies, EHR use. We need IT at the table. That physician-IT partnership is the way out, and we have to keep developing that to make sure that things improve. In administration. So I'm from Jacksonville. I'm a loyal Jaguars season ticket holder, and so every time I give a presentation, I include a picture of the Jaguars. I was all excited a couple of months ago because we're supposed to have a great team, but unfortunately our year has not gone that well, so I put the original Jaguars team up here since our team this year has been underachieving. But in honor of you guys, I include the Saints because you guys have a big game this weekend against the Rams, and so it's a great football weekend for you guys. You got LSU, Alabama, and then you've got the Saints and Rams coming, so I wish you good luck with both games. But the key is when we look at team-based care and when we look at building the right team, similar to the New Orleans Saints, Drew Brees has a role. Sean Payton has a role. The kicker has a role. Everyone has a unique role. And we need to think about that with our offices. We need to think about who owns what. Dr. Tom Bodenheimer, who's the leading expert on team-based care, came up with a study in 2013 estimating that 24% of the work that a physician does can be done just as well by someone else in the office. And so we need to look for that 24% of work and see what our team can assist us with.
So we put together some questions that we get, since we knew that maybe after his discussion we wouldn't have too many people asking questions, but we encourage you, please, if you have a question, let us know. So the first question we have, Dr. Scuderi, is do you currently integrate behavioral health into your practice? If so, how have you been successful, and share any barriers you have or have overcome?
So 3 years ago, we hired a part-time licensed clinical social worker, and we share her with 3 other offices, and it's been highly successful. It's been really great to get access in for the patients who are struggling because it's so difficult. Jacksonville lacks a lot of psychiatry and counseling options, and so having someone in the office that we can get patients in acutely has been a real great asset. Commonwealth, again, leading just innovations, has made her into telemedicine counseling, and they've been doing that with her, and it's been very successful with that population. They've really embraced that, which has been a great thing, and so that's been a successful part. We faced 2 challenges with the licensed clinical social worker. The first was the first year and a half, getting her on all the insurance panels was a challenge, and so we had to make sure we're innovative and making sure we're getting reimbursed, but once we did, it's been very successful. And the second is we're trying to expand this. It's been not only successful for our patients and our patient satisfaction for our practices, but then we've also looked at it from a budget-wise that it's been successful. And so we're trying to expand it to other practices. We're having trouble finding licensed clinical social workers. We're in the process of trying to hire them. So I don't know how it is in Louisiana, but in Jacksonville, it's been a little bit of a challenge, but we do want to expand it to all of our sites because it's been a very successful program, and I think a great asset for the patients and the practice.
Hello, I'm Heather Lennox. I'm the Care Transformation Consultant for the Lafayette, Lake Charles, and Alexandria area. My question for you, Dr. Scuderi, is how do providers incorporate shared decision-making with patients?
Thank you. So I think there's opportunities, especially when we're prescribing medications, to sit down with our patients and look at what is important to them. You know, as we have patients who are diabetics and we're moving to a second agent beyond metformin, it's a great opportunity to talk to the patients and say, okay, what is important to you at this point? Is cost important to you? Is weight gain important to you? Is lowering your cardiovascular risk important to you? Is the risk of hypoglycemia important to you? Is weight gain important to you? And then talking to your patients and realizing that there's no perfect medication out there, that we have to find the best fit for you. And for every person, that's different. So sitting with our patients, understanding what motivates them, understanding what their needs are, I think is the key to having shared decision-making.
Hello, I'm Kristen Gradney. I'm a care transformation consultant in the Baton Rouge area. What recommendations do you have to encourage or partner with specialists to provide collaborative care?
So this was very important to us because we realized, you know, when we looked at our registries at UF Health, there was 3 areas that we depended greatly upon with our specialists, and that was our diabetic eye exams, our colonoscopies, and then our diabetic foot exams. And so our registries were driven off of codes that had to be used. And so it took about 2 years of constantly working with each of those departments to say, can you please use these codes? Working with the GI department saying, please, when you do a colonoscopy, can you please update the screening interval correctly after you complete the colonoscopy, because it automatically deferred to a certain area. And so it took a lot of work with these groups to say this is important to us. But one of the things that helped is we looked at our value-based funding that came into our system to say, the better we do, the better we all do. And I think that got them on board. And then they've got great leadership. And so they were motivated. It just, like any change, takes time. You have to keep working with them, keep reminding them, keep saying until it becomes part of the culture. It usually takes about a year or two. But it's very important to work with those other providers to say, this is important, this is where we're going. We need you to join with us.
Hi, everyone. I'm Danita Lee. I'm the Care Transformation Consultant for the Baton Rouge area. My question is, can you share with us how you risk stratify your patients and how you identify each population?
Sure. And so this is using the registries to their fullest. And so with our registry, we're able to break down and say which one of our patients have an A1C greater than 9. So those are the patients we want to target. Which one of our patients haven't had an A1C in greater than 6 months. We know we need to get those patients in. And then we're able to break down each of the registries that way. We're excited. We've got our IT teams working very closely building predictive analysis tools. And so we're really excited. We're getting very close to having a readmission tool and looking at predicting ER visit tool. And so this is going to be our next goal over the next year, is how do we incorporate those into our workflows and identify which patients we need to bring in more often for that. And so it's that marriage. I know I've stressed that about 10 times, but we have to work closely with our IT teams. Our IT teams are fantastic, but they're not used to seeing patients. Physicians are fantastic, but they don't know how to build code. And so how do you marry the two so that way we can have the best systems we can have?
Hi, I'm Courtney St. Germain, the Care Transformation Consultant for the North Louisiana region. And my question, Dr. Scuderi, is what strategies has your practice found success with in preventing your patients from going to the ER with non-urgent needs?
So, one of the things that we've done to really help with that is we've expanded our hours. We start 7:20 in the morning and we go to 8 o'clock Monday through Thursday. And so having those expanded hours makes a big difference. And we're lucky we've got a provider that doesn't mind working to 8 p.m. Monday through Thursday because it's huge, especially for your working population. It's very difficult for people to get days off. And so that's made a big difference. The other thing that we've done that's been very successful is we've committed to using the MyUF Health app and using it regularly. And one of the biggest complaints our system gets is we have a central call center, and they do a fantastic job. They get beat up on because patients can't call directly into their offices. They have to go to a call center, and then the message gets sent. And so the call center becomes just kind of the enemy, but they're not. And so what we've done with our patients to get around their negative feelings towards having call center is say, please use the app. If you have an urgent issue, let us know that you need to get in, you're having trouble getting in. And I have one staff member that's working that box all day, so our patients know that, hey, if there's an issue, I'm not able to get in, that they can get in. And so I think that's been very successful too, just having the patients know that they have a way they can get a hold of us. I think most patients really get frustrated when they feel like they can't get a hold of you when they need you. And so if they know that they have an access of entry into getting information to you, they will rest easily. One of the things that we also do too, whenever I take a new patient, is I let them know what are my expectations for communication. That how do we communicate with our system? How do you work with the call center? If you have something urgent, how do you get a hold of us? And so that's been successful also. Commonwealth has expanded to Saturday hours. I think that's great too. It's difficult. We all need a life. We have to prevent burnout. But if you can find ways to stagger staff and do that, we have to meet patients where they are. It's a competitive marketplace today, and people are very busy, and they want care that is easily available. And so we have to meet our patients with that, and then that's changing. And so we need to think about that when we're scheduling our patients.
Hi, I'm Adele Wildman. I'm one of the Care Transformation Consultants in the New Orleans and North Shore area. And one of my question that just sort of follows off of what you just said about the expectations with communication, and how do you open that conversation with the patient when they come in? What is your recommendation for communicating that expectation about and the patient's responsibility in being part of the patient care team?
So I typically tell my diabetic patients, even if I see you 4 times a year, there's 364 days, 22 hours that you're going to be without me. And so I have to teach you how to fish. If I teach you how to fish, you're going to be able to feed yourself and your family for us a year. If I give you one fish, you're going to eat once. And so it's important that we have to encourage our patients that lifestyle interventions, that them taking care of themselves, them being empowered is the most important thing we need to do. One of the things I try to do with my patients just when they're leaving is to give them one goal and say, this is your one goal for your next visit that I want to see between now and the next visit. Because if we give them too many, they're not going to be able to work on it. But each patient, if we give them one thing, one goal, they typically will achieve that. The other thing is our patients need a lot of encouragement today. People really struggle with feeling valued. It's amazing. We're connected by social media, but we're more isolated than ever. And so it's important that we provide our patients with encouragement, that they're worthwhile, that taking care of their health is worthwhile, that making proactive changes is worthwhile. And so we need to encourage our patients to do that.
Do we have any questions from the audience yet? No? Okay, we'll keep going. Okay, the next question we have is, how do you handle patients that are unhappy because you will not order a test or medication that is not supported by guidelines or evidence-based medicine? For instance, a patient presents with acute bronchitis on day 1 and wants antibiotics, or a patient with uncomplicated low back pain that wants an MRI of their back on episode day 1 with no complications that warrants the test. How do you handle that?
So that's a challenge. Patients have a lot of expectations, especially in today's world where, a lot of patients have high deductibles and high copays for a visit. They want to get their money's worth out of that visit. And so it's a couple different ways. I think the first thing is taking time with patients to explain to them, this is what's important. You can always pull up to date or pull up, we have it as part of our system. I can show them what the current guidelines recommend. There's two ways that, I usually try to do to address this issue. One is I'll always offer my patients, if you're not better, come back 2 days from now, be here at 7:45 in the morning. I will work you in. I will not charge you a copay. And so that way they know they have an out, that if they're not better, I will see you. The other thing is, I let my patients know I will respond to you via the MyChart portal. So if you're not better, know that you have a way to get a hold of us and that we will, take care of you. And I hope over the past 4 years I've built trust up with my patients. I communicate with them regularly that they're able to do that. But it's a challenging situation, and there's certain patients you're not going to make happy. I think at the end of the day, too, we can't make everyone 100% happy. Sometimes we have to do what's right. We have to, we have to weigh that, and we have to weigh, but communication and giving patients an out, I think, is the best way to handle it.
What would you say to someone who says they think things like social determinants of health, barriers like lack of transportation, and coping issues are not part of primary care?
So I let them know about a conversation I had as I was flying over here via email yesterday. So I have a patient who's a wonderful lady. She's 80 years old. She has very severe CHF and COPD, and her husband still works in his 70s to help pay for a lot of their issues. And so when she gets a flare and she can't breathe, even though she lives 7 minutes from my office, she calls 911. And every time she calls 911, she gets admitted. And so this is a frustration. So I asked our nurse care coordinator, can you please reach out to her insurer to see if there's any way that we could provide her transportation? Because if we get her in the office and see if this is more CHF, is this more COPD, we can tell her treatment, hopefully keep her out. Made it to the higher levels of her insurance company and said, unfortunately with her plan, we don't provide transportation. And so this is a big deal. I mean, there's reasons why people struggle, and so we have to identify why our patients struggle. There's usually some reason behind it, whether it's a social reason, whether it's untreated depression or anxiety, whether it's substance abuse related, whether it's a family issue. And so that's really where the art of medicine comes in, where we have to see what is causing the patient to struggle. And, as we stressed earlier in multiple presentations today, social determinants of health are huge. They're becoming bigger and bigger. I think it was 80% of the factors relate to healthcare. 20% is on us, 80% is on those factors. And so we have to realize that that's part of the whole patient from a holistic perspective.
What tips and tricks would you recommend for engaging patients that are not engaged or have historically been labeled as non-compliant?
And again, this is just letting patients know they're worthwhile. I think people struggle a lot of times with feeling that they're worthwhile or feeling that they're worth taking care of themselves. A lot of people have a very fatalistic attitude towards themselves. And so if you let patients know there's a better way, you can take care of yourself. I've had multiple patients in their 70s lose 50, 60 pounds. I had a guy this week that's lost 60 pounds and has come off of multiple hypertension medications. You're not too old to do that. It's harder as we get older. It's harder with multiple diseases, but we need people to know that you can still make changes. You're still capable. You have to take responsibility. You have to be purposeful with your changes. And so I think looking for what is the motivational point, what is the person struggling with, why aren't they making changes, and how can we support them? And that's the biggest thing. It's hard, and it takes time. And this is where we really struggle with only having 15-minute visits, being that fee-for-service world, kind of, because it sometimes takes time to get to what is the heart of the matter and why are patients struggling.
What strategies have worked for your practice in getting patients that use tobacco to decide to take actions on cessation? And what strategies have helped to move patients forward in making a decision to change their behavior?
So I think repetition and shaming, I think helps. I think we just have to keep saying the same thing over and over. But one of the things I've seen really has been a great tool in the past 3 years has been since the low-dose CTs have been implemented. It gives me a chance to review with patients. Number one, when a patient realizes that they qualify for that, you say, now I'm at high risk of lung cancer. So now it makes it real. And then a lot of times when you get those results back, you'll start seeing, so they don't have a nodule, but maybe they have emphysema, or maybe they have evidence of atherosclerotic disease that you could talk to them about. And so it gives you a chance to say, okay, here's a view inside of you and how smoking is hurting you. And now it is real. Now this is their body. This is what's going on inside. Now patients are motivated to change. Younger patients, just keep talking to them that every 10 years, you're losing that window to stay healthy. The sooner you quit, the better you're going to be. And then we talk about what is holding them back. For many patients, it's anxiety. When they're anxious, they smoke. And so how do we treat their anxiety? How do we make sure that they learn better coping mechanisms to deal with their anxiety? Because it's typically most patients, they're reaching for this when they're stressed.
That is actually all of our questions. Do y'all have any?
That was a great presentation. I really enjoyed it. I had just, well, I have to share one other thing. When I sort of glanced up from my paperwork and I saw you surrounded by our care transformation folks, I thought about Andy Garcia on The View with surrounded by the panel of folks. No, in all seriousness, I really enjoyed the presentation. One of the things that you hit on that I'm really curious about is really as you look across the social determinants that we're all concerned about, sort of what role in the marketplace do you see for the stakeholders in the healthcare market? So what's the plan's role? What's the practices role? Maybe even what's the societal role in things like transportation, food deserts? Do you have an opinion to share?
Sure. I think it's best when there's redundancy. So I think that, the plan, you know your patients, you want to see them doing well. I think having assets to do that, I think makes a difference. I think having the physicians and the providers aware of what the challenges are, I think makes a difference. And then I think you need a partnership. How do you partner with the food banks? How do you partner with transportation? The local transportation. We have JTA in Jacksonville that has a rideshare program. How do you get them involved? How do you get the food banks involved? How do you offer cooking classes to show people that you can cook, reasonably healthy, cheaply? That it's not. There's ways to do it. The biggest thing, and I think the biggest challenge I see is now we've developed a questionnaire for our patients that using the MyUF Health app that they're going to be able to fill out their own social determinants of health at home because patients have been shown to be more honest when they do it at home. But then the question is, and my worry and the thing that we're still playing with in Jacksonville is how do we get that information in a meaningful way to the physicians? How do we get that information? Because we don't want to overwhelm. I'm overwhelmed every day. I have 10 phone calls to make, 25 email messages, 25 results to go through at the end of the day. How do we get that information in a way that's meaningful? And that's, I think, the next key issue that we have to determine. It's great information, but how do we build into our workflows that we're not overburdening already burdened providers? And I think that's going to be the biggest challenge in the next year.
I do have one question kind of going off of what he just commented on. In a practice, how are you with your oversight dealing with the administrative burden that being a either patient-centered medical home or a metric-driven care practice does? Is there protected time for that, and do you implement that for the providers? And on that, do you have an expansion of the care team where the metric, and I'll call it a burden for lack of better words, is shared for specialty, as in hypertension to cardiology versus you did a colon cancer screening, but if the burden is you send them to GI and they don't follow up and do the colonoscopy and stuff, who shares that burden and why should it always be on primary care?
Sure. So, we give our medical directors half a day. It's not enough. You need more time. But each practice has an office manager and has an administrator. And so they have to, work together to do that. It can't fall squarely on the physicians. And then the lead MA, that's where that team-based approach really makes a difference. We have to look at, how do we do this? And then the hope is, my greatest hope is as we move to value and we get away from having to see 25 patients day in and day out, that we can really look at how do we use our appointments better? How do we provide time because we're being reimbursed for giving quality care? And that's the hope that we will eventually move to. But it's not enough time. But you need to, at least I encourage everybody to stop once a month, close down for half a day, meet, review, discuss, innovate. You need that time. It's a great time. The second thing with how to engaging, ultimately we're responsible. The cardiologists do participate, and I think that as we move to more accountable care organizations, you're going to see more and more everybody has buy-in at that point on wanting to see the patient succeed, wanting to use low-cost medications, wanting to make sure the patients are hitting their goals. And so I think that as we move towards that, you're going to see more and more of that. But I've seen, even without that in our system, a culture shift, that they're participating. They're realizing that we've gotten we've seen, there's a graph of our value-based funding over the past 10 years. In the past 3 years, it's gone up exponentially. And I think that that's motivating everyone. Everyone's seeing we're at a very challenging, UF Health, takes care of, we're the safety net hospital for Jacksonville. And so our margins are very thin every year. And so that value-based funding has allowed us to thrive at a time where we'd really be struggling. So I think making that everyone's aware that this quality makes a difference is important.
Okay, I want to thank Dr. Scuderi and our panel for providing a very educational interaction for us. Forward this line.